these speech and swallowing programs you're chatting about, how do we find them? How much do they cost? Are they covered? All those sorts of things.
Okay, those are good questions. So here, my fees, I believe, are listed on the website for.
Okay.
So if you have extended health coverage, then many extended health coverage benefits do cover for speech services through LB. In terms of Ontario Health at Home or obtaining a video fluoroscopy through the hospital setting, then those will be covered through OPIP. And those typically are referred from a physician. Or through Ontario Health at Home, it can be from your physician, or you can self-refer, or family can refer. Any other questions? Okay, okay, thank you.
So, being amongst these therapists, I had to get up and say something. And, you know, as a physician, you know, I prescribe a lot of pills, I adjust a lot of stimulators, and I see the patient for, I see the patients for, you know, half hour, and we go cover a lot. But I am so, to the point of embarrassment, how physicians do not utilize the help of the therapists. And I think a lot of it has to do with reimbursement issues and coverage issues. But I can tell you, one of the major causes of death in patients with Parkinson's disease is aspiration pneumonia. Food or liquid get down into the lungs, causes pneumonia, and the patient dies. The problem is that 25% of patients with Parkinson's disease are what we call silent aspirators. So they're not choking, they're not gurgling, they're not coughing. And the next thing you know, they wind up in the hospital with pneumonia, and then from being in the hospital with pneumonia, that's off to the nursing home. It is so critical that these patients be seen by speech-language pathologists. And there's a lot that can be done. Sometimes it's not eating or not eating, sometimes it's what you eat, how you eat. So there are ways to deal with this and reduce the risk of pneumonia. Falls are a major, if one thing frightens me the most for my Parkinson patients is a fall, because I know a fall risks a fractured hip, a fractured rib, a compressed spine. Next thing you know, they're in the hospital. Next thing you know, they're in the nursing home, or worse. Okay. So physical therapy is extraordinarily important. There's definite evidence in laboratory animals where exercise increases what we call nerve growth factor. That's very important for brain cells to survive and to grow. And so physical therapy is extraordinarily important. But also, I actually made house calls every now and then, and I walk in to the house and I say, where in the hell is the occupational therapist? Because I'm seeing scatterbugs, and I'm seeing little end tables, and I'm seeing and I'm saying, oh my God, you know, something's going to happen here, okay? It is, and this is a huge problem with chronic illnesses. You tend to become very focused on what the doctor can do, what the nurse can do, and they lose sight of how critically important it is for speech-language pathology, occupational therapy, physical therapy, recreational therapy. All of these things are so critically important. And I have to say, my impression of my colleague physicians is we do not pay nearly enough attention to these issues. So I'm so grateful to hear these therapists here speaking today. So it's wonderful. I would like to applaud them.
Questions. So if you have any questions for any of our speakers here, feel free to raise your hand and we'll go from there. Yes.
Oh, go ahead.
Okay.
Okay, Mike. I'll go ahead. Okay, so my Parkinson's brain's forgotten the doctor's name again.
Oh, Dr. Montgomery.
Montgomery.
Yeah.
I'm just wondering, what is the holdup with neurologists like, mine's retired, I know other people's are retired in this area. And, is it too hard a job to get into? Is it take too much schooling? What is it? Why don't we have more?
Yeah, exactly.
Yes.
Come out of retirement.
That is a very, very sore subject.
Oh.
There is a horrendous shortage of physicians, not just neurologists. In Canada, it's estimated that we need another 23,000 family physicians just to get everybody in to see a family physician. And in Canada, not like the US where I spent most of my career, in Canada, if you don't have a family physician, you don't have access to care. I mean, it's just that serious. Okay? There is a horrendous shortage of movement disorders neurologists. An average new movement neurologist, I would say at least half of them don't see new patients because they're so booked up with the patients they have a commitment to. So it's a horrible situation. And I also think, in my opinion, is that we have a very warped, misguided healthcare system. And this is true, it's true in the US as it is in Canada. And we don't have enough coordination between the family physicians and the specialists. So my strategy is that I have a family physician refers to the patient. I'll see that patient. I make sure the diagnosis is correct. I go over all the medications and develop a strategy, a care plan for that patient. I send the patient back to the family physician and say, look, I want you to do these things, these things. And I give them 10 pages, not 10 pages, but 5 pages, 6 pages of instructions about if this happens, do this, if this happens, do that, this happens, do this. And at the bottom, I give my home phone number. So I say, if you have any problem with my recommendations, 24/7, call me, okay? I've actually volunteered to have my Parkinson clinic in a family medicine clinic. And so I say, okay, give me a room, I'll see my patients there, and if you have a patient in your clinic that you have a question about, call me. I'll walk across the hall and help out. Okay? And these kinds of things don't go. These kinds of integration, I talk about integration with therapists. Integration among physicians is 10 times worse. And unfortunately, we have this terrible battle between family physicians and specialists. And there's a long history of this that goes way, way back. But in my opinion, the critical thing is the family physician is the focus of care. That is your gatekeeper, that is your home base. That's where you get to everything else you need. But that's only going to work if there's a better communication, a better cooperation among all the different physicians. And I don't know how we're going to do that, but I think in large part that's going to be up to you to drive these things.
Oh, Mike was up first and then I'll.
No, go ahead.
I'm just gonna say related to that, I'm newly diagnosed with Parkinson's and was told I have a 2-year wait for a neurologist in New
Yeah.
Hampshire. So I'm just saying, what does a person like that do in the meantime? Because I've already had
Good
new
question.
symptoms, but I don't have.
Yeah.
So this is, when I first started in movement disorders, I had availability for about 5 years. And then I actually had to close my practice. And my practice was very small because I was doing a lot of research and a lot of teaching. And so I just couldn't take any more patients because I couldn't deliver care properly to the patients that I had. But then I learned something very late in my career. There's this wonderful thing called nurse practitioners.
Yeah.
And I'm telling you, it was amazing. It was amazing. So I always insist on being first to see the patient, not the last. I see the patient not after the receptionist, not after the nurse, not after the nurse practitioner. I see the patient first. Okay. Then I sit down and come up with a care plan that I work with the nurse practitioner, and I hand it over to the nurse practitioner. And the nurse practitioner carries out all the different plans that we've created together. And she always gives me, or he always gives me feedback. Every 3 months, we have a case conference where we review the patients, make sure they're on track, doing what they need to do. And I discovered then that all of a sudden, my waiting list went shoot. And all of a sudden now, I was able to see a lot more patients. Okay? That was in the United States. In Ontario, the whole scheme for financing and supporting nurse practitioners is crazy. I tried for the 4 years I was practicing here. I tried to get nurse practitioners involved in our clinic. No success. So the long-term answer is we need to train more physicians. Just no doubt about it. We have to train more physicians. Number one. Number two, we gotta get this family physicians and specialists on the same page, working hand in hand. Okay, those are long-term solutions. In the short term, we need to take advantage of nurse practitioners, physical therapists. I actually work with physical therapists to help me treat my patients in terms of medication adjustments. So I said how these patients are up and down, up and down, up and down. If I see them on my plate and they're in a good stage, I think the patient's doing great. I just happen to see the patient when they're in their down phase. This is terrible. How am I going to practice medicine? So I would send the patient to the physical therapist, would evaluate the patient on the hourly basis through the entire day. And I would get a graph, and I look at that graph, and I say, okay, we need to increase that dose there, we need to move that dose over there, we need to move that dose over there. But that's the kind of effort that we need. In the immediate term, I wish I had a better answer, but we have to be advocates for your care.
So I should rely on the family physician?
Sorry?
I should rely on the family physician at the moment?
But you rely on, so I firmly believe, because of the issue of atypical Parkinson's disease, and we know that a lot of the medical decisions you make early have profound effects on how you're going to do over the long run. So you need to be seen by a specialist right up front. That doesn't mean that the specialist does the day-to-day care after that, but there are very critical issues about what kind of Parkinson's are we dealing with, what kind of additional medical issues are involved. And these are complicated issues. And family physicians are brilliant doctors, they're great caring doctors, but they've not been able to devote their entire career to Parkinson's disease like I have.
But I've been told I have 2 years to wait for Dr. Conley.
Get on the wait list, call, and make a nuisance of yourself. Call the neurology clinic on a weekly basis.
Squeaky wheel gets
At the same time, and groups like this can get together and pull your weight together, but there has to be some very fundamental changes, and the only ones that are going to push those fundamental changes are you all. They're not going to listen to me.
Thank you.
The other thing I've heard recommended is if you can't get into a movement disorder specialist specifically, at the very least try to get a second referral to a neurologist.
That's a
in the
year.
account.
That's a year.
Yeah, okay. As
That's
long
what I
as
was
you've got
told,
that.
2 years for the movement specialist
Yeah.
and a year for the
Okay,
neurologist.
just as another thought.
But the other thing is to educate yourself.
Oh, I am.
That's so important, because the squeaky wheel gets the grease.
Thank you.
Doctor?
You got a telephone, I'll give you a telephone number for you.
Yeah.
905
No.
356 4732. That's my wife. She can put pressure on anybody. I'm telling you, I'm feeling for her because they told me, I got in the hotel with Shaker, and the gentleman over here is the boxing guy.
Yeah.
Hard boxing, and I want him to say a couple words too, if I could, sorry, please. I don't
No, I
want to
would
take
love
over.
that, yeah.
But folks, do you understand what I'm saying? I got a PhD, it's a pool hall diploma. But I'm smart enough to realize that you can get stuff done, but like when I asked her, can we not raise money? Like the reason I got out of hotel due date, first of all, the lady that ran it, and this is on my father's grave, she said, there's no need, we don't have any Parkinson's in Niagara. And I was lucky, there was a guy named Rick Dykstra who walked in and said, enough of your bullshit, and then here's what we're gonna do, we're gonna open the best Parkinson's thing we can. And how are we gonna fund it? I'll fund it, I'll raise money for my goals. So when I asked you, can you not come out and help a little bit, just something? We'd eat this place up. There's no reason this should be 3 years. I got told the exact same thing. I said, hey, 3 years? You kid, I'll be dead in 3 years. Going like this.
Yeah.
So what I'm saying is, you gotta, like, the core coming back to me, Ronnie. Like, you gotta look after yourself. And then if you get band together, that's why I got behind these people, because I could see what's gonna happen here. It's gonna be great, it's gonna be fantastic, but you gotta, things need money. You need some money, you gotta do something to get people's money so you get it. That's all I can say.
Band together.
Band together, yeah, exactly, that's why I picked this place to help them out, if I can help anyway
Yeah,
with roads
exactly.
and this, that. That's a nice check to put in the bank, $150,000. It's nice. I can't remember your name, sir. Martin? Mario, I'm sorry, Mario, Parkinson's. He runs a good box. I just said I should have mentioned that boxing, but hey, when I'm up there talking and said, I was trying to hope you guys understand what I'm saying. You gotta look after yourself. The government ain't gonna do it for you. You gotta do it ourselves. That's the way it's gotta be.
Question for the doctor?
Yes, go ahead, Mike. Mike, right?
Yes. What, is there anything one can do about their fatigue?
Fatigue?
Yes.
Yeah, that's a tough one. That's a tough one. First thing.
Because there's lots I want to do, but I'm tired.
Yes.
I'm very fatigued.
So, first thing you have to do is you have to say, well, there's a whole lot of things that could be causing fatigue. A lot of things. Okay. What's your thyroid status? If your thyroid's low, you're going to be fatigued. What's your cardiac function? That's your heart being able to pump enough blood and to supply that to the muscles. Are your lungs functioning properly? Okay. So there are many different factors that are involved in fatigue. And a big factor in fatigue is trouble sleeping at night. And that's a terrible problem for many Parkinson's patients, is sleeping at night. So the first thing if a patient says they're feeling fatigued, I go to what we call a differential. Could it be this, could be that, could be this, could be that. Many times it is what we call, I'm blocking on the name, but physical therapy can be extraordinarily helpful with that, okay? Because by building up your exercise, you're building up the muscle endurance in the muscles, you're increasing your heart function, you're increasing your lung function, and what was mentioned, what we call aerobic exercise that gets your heart rate up. We know that kind of exercise, at least in rats, increases what we call nerve growth factor, which is very important for maintaining the neurons that you still have left.
Yeah.
So I think physical therapy, exercise is very important. And I think it's very difficult if someone just says exercise. As the therapist mentioned, well, there are exercises and then there are exercises.
Yes, exactly.
So you gotta make sure you're doing the right exercise that's gonna meet your needs and that's gonna be safe for you. But again, you have to go through the differential. How are you sleeping? What's your heart condition? What's your lungs? What's your thyroid? What's your hormone status? What's your cortisol levels? So there are a whole bunch of things that need to be answered. And then if it comes down to the fatigue from Parkinson's disease, which is extraordinarily common, then physical therapy is probably the best. And the other thing that's very helpful is good health hygiene. Sleeping well, eating properly, being happy. Major cause of fatigue is just depression. Depression can cause it, and we know that patients with Parkinson's disease are at much higher risk for depression. So I always inquire about the issues of depression. And the worst thing about depression is that it goes untreated. It goes untreated. There are very effective treatments for depression. I mean, and a lot of times treating the depression helps the Parkinson's disease as well, not just the fatigue. So first thing is what are the contributing factors to the fatigue? And if you ruled out thyroid and all these other things, to the physical therapist.
So essentially you're
Thank
stuck
you.
with me, Mike.
Yeah, unfortunately.
I'm also going to jump in on that one too, because not only is the exercise piece important, and not to
plugging myself shamelessly, but one thing I do is energy management counseling, so we can talk, if all the medical stuff has been looked over and you've ruled out any, outlying medical reasons why you're having that fatigue, then I work with people on, how do we spend our energy in the day? Are there pieces of the day that are happening that are taking up more energy than we think they are? The doctor mentioned about sleep hygiene. I work on sleep hygiene with my patients too. So a lot of those lifestyle factors are things that I'll help you break down, and we can work on together to create a plan to support your energy and being able to do the things that you want to do.
Thank you.
Yes.
Hi, I have a question for Dr. Montgomery. I am curious if you know, what are the clear indicators that the medication is working?
What's the clearest indication that the medicines are working?
Yeah.
It's when you're doing great. Short of that, the first assumption is the medicines are not doing great.
Tremors, are they supposed to decrease?
I'm sorry?
Tremors, are they supposed
The tremors? Okay, so what we shoot for is not necessarily are you shaking, not necessarily are you slow. What we shoot for, are you able to enjoy yourself? Are you able to do the things that make you happy, your family, your friends happy? That's what we shoot for. There are a lot of people that have tremor and it doesn't bother them. So we're not overly aggressively in terms of treating that tremor, okay? Some people are a bit slow, but it's more, their slowness is more of a bother to everybody else and not to them. Okay? So we need to be very, very clear about what is it that we can do for the patient. We want the patient to do everything that makes them happy, makes their family and friends happy. Now, tremor is an interesting thing. Sometimes tremor will respond to one group of medications or not another. So sometimes adjusting the medication can help. If the tremor is particularly bothersome, we can adjust the medications that are more specific to tremors, and that's one option. But the other thing is, deep brain stimulation is extraordinary at stopping the tremor. I can remember being in the operating room, we put the electrode in place, and the patient's shaking like this, turn on the stimulator. It is truly, truly amazing. Now, if a patient has a severe tremor and it's interfering with their quality of life, they can't be happy, they can't make their family and friends happy, and they try a good try of the medications, and otherwise they're in pretty good health, deep brain stimulation is amazing, amazing.
Yes, I had another question about medication for Dr. Montgomery. We recently returned to Canada from overseas and are having a hard time getting medication for my husband. So he's traveling overseas every 6 months to pick up medication and bring it back because we can't get care very similar to this lady, saying the length of time. Can family doctors prescribe, or is this just neurologists?
I have to be careful because I was only a Canadian physician for a few short years, so I don't know the ins and outs of it. But I suspect that it's not a whole lot different than it is for U.S. physicians. But, so there are a couple of things. So there are different categories of medication. There is approved medications, and experimental medications, and investigational medications, okay? And so there are regulatory issues surrounding those. And then there are issues about transport of medications across countries. So there may be a medication that's approved in Europe, that's not approved in Canada, so there may be some regulatory issues in that. When I practiced in the United States, I would recommend my patients go to Canada, because in Canada they had a medication called domperidone, which was extremely good at getting rid of nausea and vomiting. But we couldn't get it in the U.S. So I would say to patients, I want you to go across the border and get yourself some domperidone from the Canadian doctors, and when you're while you're there, bring me back some domperidone. So there may be regulatory issues that cause that. The other issue is if it may be accepted use in Europe and investigational or experimental in Canada, that's another issue. But here's the thing. a physician can lobby for you. A physician can lobby for you. So, for example, there was another medication that was experimental in the United States when I was practicing in the United States called tetrabenazine. So I worked with the FDA to get special permission to use the tetrabenazine for my patient. I had a raft of paperwork that I had to fill out, but it is possible for physicians to appeal for what we call non-formulary medications. So it may very well be possible for your physician here to appeal to OHIP, to appeal to the insurance company to provide that medication.
So the neurologist that we have could provide the prescription, the protocol that's working right now, and then maybe the GP here, if we can get in one, could give us a prescription. Now, we know one of the drugs isn't available in its format in Canada, but we think it can be shipped in and the pharmacist requests it. I don't know, it's very complicated.
I apologize, I didn't catch quite all of that, but I don't know of any medication that requires a neurologist as opposed to a family physician.
Any doctor can prescribe anything that they want. I'm a GP. Any doctor, you can prescribe anything.
My GP has me on the levodopa carbidopa, so I don't have to wait 2 years to get on that.
Yeah, so there are workarounds here. You just gotta be persistent. As you say, you gotta fight for yourself. You gotta be your best advocate. You gotta be your best champion. So
There are differences across provinces as well. So each province has a different set of drugs that can be administered. And you can go across provincially sometimes and get a physician out of province to get you what you need. So that is another thing that you have to do.
So in fact, I did just that sort of thing. So in the United States, I had a patient that needed domperidone or needed one of these medicines. I would write a letter and a script. I would send it to the Canadian doctor. The Canadian doctor would translate that to a Canadian prescription. They'd give it to their pharmacy in Canada, and then Canada sent it to my patient. So there are these workarounds. And as I say, even if they're not approved in Canada, you still may be able to get it through an exemption waiver.
Thank you.
Why are there so many diagnoses of Parkinson's?
So you're saying that prevalence or it's increasing too? What
Okay, so yes, Parkinson's disease is a fairly common disorder. It's estimated that if you take 100,000 general population, 10 to 20 of those people are going to have Parkinson's disease. Okay? We also know that your risk for being diagnosed increases over age until you get to about 80, and then it plateaus off. So Parkinson's disease is a common disease. We don't know what causes most Parkinson's disease. There certainly is a subgroup in which it's genetic. There's a family predisposition to have it. And in fact, there have been, well, at my last count, 7 different genetic abnormalities that are associated with Parkinson's disease. So in certain situations, we will do genetic testing. Most of the time, the genetic testing is only, doesn't change the way we treat the patient, but sometimes it'll make a difference to a family member, son or daughter, for them to kind of think about what their risks. If you just take Parkinson's disease in general, if you have a father, mother, brother, or sister who has Parkinson's disease, your chances are only about 2 out of 1,000 of getting Parkinson's disease. So it's, I'm sorry, if I made a mistake on that prevalence, it's 100 cases per 100,000. If a family member is at a slightly increased risk, but if you have one of these genetic abnormalities, then that changes the risks for it. And I think the other issue is we're becoming much more aware of the diagnosis. But even now, it's severely underdiagnosed. So there have been community surveys where doctors and nurses would go and knock on the door of every house in a district, and they would find about 20% more patients with the disease than were diagnosed. In other words, it's terribly underdiagnosed.
In the back?
Just wanted to know your thoughts on the B1 therapy.
B1?
B1 therapy? Okay, so we don't know of any specific nutrient or mineral vitamin that is particularly helpful for Parkinson's disease patients, but I'm telling you, if you have a vitamin deficiency, that's going to make your Parkinson's worse. Okay, there is one exception, and that's vitamin B1. Okay, and it can interfere with some of the medications. But for that to interfere with the medications, you have to take industrial quantities of it. So the kind of that B1 that you get in your diet or multiple vitamins is not going to be a problem. But for patients who were on certain medications for like tuberculosis, we had to give them a lot more of that medication, of that vitamin. And some of those patients could make their Parkinson's a bit worse. So bottom line is well-balanced nutrition, proper food, proper variety, vitamins and minerals. It's just good health. That's just good health. It's even more important if you're dealing with a chronic disease like Parkinson's disease.
Yes.
So in the past, I know creatine supplementation hasn't been well supported in research, but has there been any like emerging research or anything to support it now, or is it still the same?
Emerging research for what? New supplement.
Oh, creatine, and so talking specifically with
Creatine, yes, okay. So the first thing you have to admit, we just don't know, okay? So we haven't done the kinds of studies that would be very, very helpful. And this is a very interesting issue. So, so there could be all these different types of things that could help in Parkinson's disease, but we just don't know because we don't have the trials. We didn't do the clinical trials to know if it would help or not. So it actually turns out it's easier to show that something doesn't work than to show that it does work. And so the National Institutes of Health had a number of clinical trials and what were called futility studies. So it's easier to prove futility. So they actually started going through a number of more common medications, supplements and things like that, because it would be easier to show if they didn't work than to show if they did. So that's a kind of strange paradox we're in. Creatine, is very, very important for a number of different issues. Whether it makes a specific issue for patients with Parkinson's disease, it's hard to say. Now, one thing about Parkinson's disease, particularly a more affected Parkinson patient, in particular a depressed patient, they don't eat right. And they're going to be prone for all those kinds of deficiencies that you just described. So it's very, very important to making sure they're getting a well-balanced diet, getting exercise, and as I say, that's just good general health guidelines, but when you have a chronic illness like Parkinson's disease, it's all the more important. So I can't answer your question specifically because we've not done those kinds of studies, or I can point to evidence, but again, I think the important thing is making sure you have a well-balanced diet, rest, exercise, and be happy.
Yeah, go ahead, then we'll get you next.
I just wanted to give general thanks to all of you for what's happened today, and I hope there's more of this. But I'd like to thank one non-medical person up there in the linen jacket. A dozen years ago, out of a lot of luck, there was a connection made with my husband, and you started him on the path to Shaver Hospital, and he's had a good 12 years that he started that. And
That's what we try to do, yeah. Thank you.
And medically, we've been lucky. Very sad to hear people who not have been neurologists. We traveled to Toronto for one, but she's excellent. And her word is exercise is medicine. And the exercise is everybody, but
I'm usually pretty happy, but once in a while, a little bit more often, I get a little bit growly. And I guess that happens when you self-evaluate too closely. I've always taught my kids, my sons.
I can't hear you.
I've always, I've always taught my sons that you're only here on this earth for a short time. Have as much fun as you can, be a good person, respect people, and deal with the cards that deal with the cards you've been given. And you can squawk and moan. I know my story is a little bit different. I believe that my Parkinson's 100% is from blows to the head. This is that. And you'll get medical people who will argue that, but it's funny how the football players got things from the NFL. Hockey players, they were like, no, they don't get hit hard enough. So I don't know what that maxim was, mass times force equals velocity. Hockey players generate that more than football players. And I can't even say how many guys there are that are suffering badly. Big name players. It doesn't matter if they're big name or not. I just lost a friend of mine, ALS, Dave Gorman, who was sick for 10 years. And he had he didn't speak the last 5. His wife looked after him, and we became great friends with him. But you deal with the cards that you got. And I would tell all your parents and grandparents, be careful with kids. Be careful with kids that are playing hockey. I love it. It's my life. But I'm not stupid. I took a lot of blows, and even if you are lucky enough not to get hit in a game, practice is banging. It's like I always explain it. It's like being on a bumper car ride at CME, being a hockey player. Bang, bang, bang. It's just doesn't feel like much. But it's just like that for 20, 30 years, and you tell me that you're going to be walking around fine after that. No, you take that chance. That's what happens.
So, I learned very, very quickly when I started my medical practice that the patient is not my patient. My patient is also the sons, the daughters, the brothers, the sisters, the mothers, and fathers, and everybody around them. You cannot treat one without treating all. I learned this lesson in a very interesting way. I had a gentleman with Parkinson's disease who was very slow and immobile and very quiet, and he was just not being treated optimally. So I worked very, very hard to optimize his treatment. And so he came back and he was doing great. I mean, he's like a new man. It was amazing. Great. So I sent him back home, and I called his wife a week later to check on him. And she said, "It's terrible, it's horrible, I can't stand it, he's terrible." I said, I just saw him a week ago, he's a rose. No, it's terrible, horrible, horrible. I said, "Well, I'll check back with you in another week." I call back and it's worse. And I'm going, "What the heck?" So I said, come in. So he and his wife came in. Yeah, I said, and I examined him, he's doing great. He's mobile, he's active, he's actually got a sense of humor, and he's happy. And I said to his wife, "I don't understand it. I mean, he's able to do things, he's active, he's interested, he's engaged." And she said, "Oh my God, he wants me to go here, and he wants to go there, and he wants me to do this, and he wants to do that, and he wants sex." She said, "At 80 years old, I'm a little tired of it." So I said, "Whoa, I gotta treat her as well." So it was a terrible dilemma. Do I back on his medicine? That would have been unethical. So we worked very hard to get support, respite care, people coming into the home to help them in that adventure. So again, the bottom line is you treat everyone around that patient. Children, I can't tell you how many discussions I've had with children and children with patients with Parkinson's. And it's a very strange dynamic. A lot of times the parents are trying to protect their children, particularly if they're younger children, they're trying to protect their children. They don't want to talk about it. But these kids know something's wrong. And they'll invent far worse things as being wrong. I've had children say, is my father who's shaking, is he a drunk? So you see, they'll think of horrible things that just, no. I say, no, he has his Parkinson's. Oh, he's got Parkinson's disease? So don't presume that you know what your children are thinking. Ask them what they're thinking. Because a lot of times they'll be thinking things far worse than are actually the case. And then the other thing for children and particularly children of patients with Parkinson's disease, as old as your father or mother get with their Parkinson's disease, as old as they get, they're still your parents. You feel for them the way you did when you were 5 years old. You don't forget that. You feel for them the way you did at 15. Well, 15's tough. So they still, I mean, I can remember being 30 years old and calling my father for advice. Now, I didn't need his advice, but I needed my father to know that I needed his advice. Okay? So it's a wonderful relationship, it's a wonderful thing, but it can be fraught too. And so I always say, don't presume what they know or don't know, and that goes both ways. Ask, because you can avoid a lot of difficulties, because people are much better at inventing monsters than could actually exist.
Okay, so we're just gonna wrap it up then. I wanna thank you all for spending the afternoon with us, for coming here, and we hope you leave more informed, more empowered, and more supported than when you came. A final thank you to our speakers for sharing their time and expertise with us.